تمام، رح نبدأ هلا بالمحاضرة. محاضرتنا اليوم نوعا ما مختلفة عن كل مرة، ورح تكون باللغة الإنجليزية بشكل كامل. وهي عبارة عن تدبير احتشاء عضلة القلب أو Managing Myocardial Infarction الهارت اتاكس. وعندنا المحاضرة هي عبارة عن هي الفارماسي كلينيكال سبيشالست بالكارديولوجي بالميد ستار واشنطن هوسبيتال بواشنطن دي سي. ويعني بنتشكر البرزنتر من هلا قبل ما نبدا انه يعني اخذت من وقتها مشان تشرح لنا شوي عن مانجينج المايوكارديال انفاركشن، وراح اعطيها لدكتوره لما قنواتي مشان بس to introduce the speaker for us. Thank you so much, Doctor, for attending. Today, our presentation will be about managing myocardial infarction. The slides were shared with the attendees, and today's lecture will be fully in English. If you guys have any questions, please send it in the chat. I'll hand it to you, Dr. Lama, to introduce the speakers. Thank you.
أهلا وسهلا فيكم. محاضرة اليوم هي جزء من عدد كبير من المحاضرات للعناية المشددة، هي ال ICU course، وجاي معكم من Pharmacy Assembly قسم الصيدلة بسنابس. محاضرة اليوم حتكون بالإنجليزي، وإذا في أي أسئلة بآخر المحاضرة نحن رح نترجم، وإن شاء الله بكون عند حصص يعني حسن الجواب. Our speaker today is Dr. Victoria Lee. And Dr. Lee is a doctor in pharmacy and board certified in cardiology. She is the pharmacy clinical specialist in cardiology at MedStar Washington Hospital Center in Washington, D.C. And the topic is managing myocardial infarctions, which is heart attacks. So Dr. Lee, I will hand it to you.
Thank you, Lama, very much. Good evening, everyone. It is nice to see everyone, and I'm very excited to be presenting this topic. So today's objective is definitely to talk about the definition of myocardial infarctions, or MIs, or even acute coronary syndromes. We will also talk about the different definitions of unstable angina, non-STEMIs, and then STEMIs. And then we'll recognize some of the non-pharmacological treatments of MI, and then to select the appropriate medications for MIs. And there has been a recent clinical guideline update in the United States that was published in February of this year. So we'll look at some of those updated guidelines for MI management. Okay, so what is the prevalence of ACS? So worldwide, it causes about 7 million people that are diagnosed with ACS. And in the United States, the CDC, which is the Center for Disease Control and Prevention, has estimated that around 805,000 people experience an ACS event annually in the United States. And then when we break down this number, about 600,000 will have experienced their first heart attack, while another 200,000 will have experienced a second heart attack. And then also they have estimated that 1 in 5 people will have a silent heart attack. So ACS causes about 1.2 million patient hospitalizations in the United States each year, and this number is believed to be projected to go over 16.6 million by the end of this year. Okay. So this slide shows some of the abbreviations that will be used on the presentation, so please refer to it if you need. So we have 3 types of MIs, or acute coronary syndromes. So we have unstable angina, non-ST segment elevation MI, and then ST segment elevation MIs. So in terms of MIs, there's really 5 types, type 1 through 5. And for the most part of this presentation, we are going to focus on type 1, which is the classic type MI that's caused by atherothrombotic coronary artery disease, which is due to the rupture of the plaque. But there are other types of MIs that are there. So there are type 2 and type 3, and then type 4, and then type 5. So type 2 is caused by mismatching in oxygen supply and demand, and this can be seen in coronary dissections, vasospasms, emboli, microvascular dysfunctions, or even in increases in demand with or without coronary artery disease. And then for type 3, it has an atypical presentation, and there is unexpected death before the biomarkers, the cardiac troponins, could be drawn. And then type 4 is divided into type A and B, and it's mostly related to percutaneous coronary intervention procedures. So during a PCI event, there might be an evidence of new myocardial ischemia from an EKG change, or it might be a procedure that had complications. And then 4B is related to the stent itself or the scaffold thrombosis that occurs during PCI. And then finally, we have type 5, which is caused by cabbage MI. And here you can see the troponin values. They are greater than 10 times the 99th percentile in patients with normal baseline cardiac troponin values. So again, we will mainly focus on type 1 for this presentation. Here I have some examples of the MIs and what is shown in the EKG. So all the way to the left, we have this normal PQRST wave, but in non-STEMIs, you can have ST depression, which is shown here, or even a T wave inversion. So those are classical signs of non-STEMIs. And then on this side, you have STEMIs, and just as the name implies, there's ST segment elevation on the ST interval. Okay, so next we'll talk about the different characteristics of the subsets of MIs. So we have unstable angina, and unstable angina is described as a new onset exertional angina that's of less than 2 months duration. It does limit physical activity. It could be previously stable, but it's now occurring with increased severity, frequency, and more duration, and it occurs with even less exertion. And this can occur also at rest. It can last greater than 20 minutes. Sometimes unstable angina can also present within 2 weeks of a previous MI, and then there could be a partial or intermittent coronary artery occlusion. And as we have seen with the other EKGs, there's ST segment depression, T wave inversion, or transient nonspecific EKG changes. So what's unique about the unstable angina is if it's not appropriately managed, it could be progressed to a non-STEMI. So for non-STEMIs, they cause severe narrowing or transient occlusion of the coronary arteries. Their signs and symptoms are much longer in duration and much more severe than an unstable angina. On an EKG, you can see ST segment depression, T wave inversion, or nonspecific EKG changes. So the most prominent thing about non-STEMIs is now you have elevated cardiac biomarkers. So we did not see that in unstable angina. So here we see a rise in cardiac troponin I's or cardiac troponin T's. And then the third subset of ACS is the STEMIs. And here it fully occludes the coronary artery. There's going to be irreversible tissue damage causing myocardial cell death. And then on EKG, there's an ST segment elevation, usually greater than 1 millimeters above baseline on the continuous leads. And then again, just like non-STEMIs, there are elevated cardiac biomarkers, so cardiac troponins I or cardiac troponin T's. So for this slide, we'll go over some of the pathophysiology and some of the causes of acute coronary syndrome. So most of the cause is due to formation of this atherosclerotic plaque with this lipid-laden core in the middle. And then this lipid-laden core can erode or rupture. And 25% is due to erosion, but much more is due to rupturing of the plaque itself, so that's 60%. And when the rupture occurs, it could cause a partial or a complete occlusive clot that forms on top of the artery. And then platelet adhesion, activation, and aggregation starts. We also have the extrinsic coagulation cascade that becomes activated. And finally, a fibrin clot forms. There are other etiologies of ACS, so I have listed them here for you, as well as the percentage of their occurrence. So besides the plaque rupturing, there could be calcified nodules, coronary spasms, spontaneous coronary artery dissections, and then also embolism can occur. And then MIs with non-obstructive coronary arteries can also be a causative reason for ACS. So here's a diagram just to show what the pathophysiology of ACS is. So on this slide to the left, you have a normal coronary artery with good blood flow. Atherosclerosis forms on top, and this atherosclerosis is considered a vulnerable plaque. So when this plaque ruptures because of this thin fibrous cap, you have now platelet adhesion, and then the blood flow, a clot forms on top, and then the blood flow gets disrupted. So this is a picture that shows clot forms around the rupture, blocking the artery. Okay, so this picture shows that acute coronary arteries can affect any one of these coronary arteries of the heart. So on the right side, we have the coronary artery and the right marginal artery. On the left side, ACS could affect the left coronary artery, the circumflex, the marginal arteries, the left ascending arteries, as well as the diagonal arteries. Okay, just trying to find the mouse. Okay, so what would be some complications of a heart attack? Well, because of the loss of perfusion during these heart attacks, we can have ventricular remodeling, and that can lead to systolic and diastolic function, as well as cardiogenic shock and heart failure. And then valvular dysfunction can also occur because there's some papillary muscle rupture that can take place during this time. And then arrhythmias are also a common complication. So you can see ventricular tachycardias, ventricular fibrillation, as well as AFib, and also bradyarrhythmias. Pericarditis, stroke, and venous thromboembolism can also occur too. So for venous thromboembolism, we see more often the left ventricular thrombus, and then we can also see the most severe form, which is this left ventricular wall rupture, and this does require surgery for correction. So the next slide will talk about some of the risk factors for cardiovascular disease. The risk factors are divided into two categories. The ones that are non-modifiables, we can't change those, and those would be age, sex, and family history. But in terms of age, for males who are greater than 45 years old and for females who are greater than 55 years old, they are at increased risk for developing cardiovascular disease. And then females, the female gender also have a higher, they have a less risk than the male gender. And family history also plays an important factor, especially if the patient has a first-degree relative, like a male or female relative, who developed coronary artery disease before the age of 55 in men or 65 in women. They are at increased risk for developing cardiovascular disease. And then for the modifiable risk factors, this is where the pharmacists and the physicians play key roles in optimizing guideline-directed medical therapy for these disease states. So we can help patients with their hyperlipidemia, controlling that, as well as their type 2 diabetes, and helping them not to smoke, as well as controlling their hypertension, giving them counseling on obesity and stress, lifestyle changes, as well as decreasing sedentary lifestyle, which is promoting more exercise and sitting less. I also wanted to mention that smoking has been shown to exacerbate myocardial ischemia, as well as decrease some of our medications like beta blockers and anti-angiogenic effects. So definitely having patients stop smoking is a key factor. So how does our ACS present? What are some signs and symptoms? So some of the signs and symptoms described are pressure-type chest pain. This can be described as an elephant sitting on one's chest. The chest pain could radiate to the arm, to the neck, to the back, or the gastric area. It could also present as severe, unexplained new onset pain and have increasing exertional dyspnea. Other signs and symptoms that could be seen are shortness of breath, tachycardia, which is fast heart rate, tachypnea, the GI symptoms such as nausea, abdominal pain, lightheadedness, syncope, diaphoresis, and it can definitely limit the person's daily activities of life. And then in those who present with non-STEMIs or STEMIs, their signs and symptoms are much longer in duration and they are much more severe than in an unstable angina. Okay. We also have the atypical ACS symptoms that could show up as unexplained fatigue and lethargy. It could also show up as indigestion, having nausea and vomiting, epigastric pain. There could be diaphoresis, syncope, anxiety involved, and it could also occur without chest pain. So these atypical ACS symptoms are seen more in the female gender and in the elderly patients. And then we also have another set of clinical presentations that are described as silent ischemia. And here, patients can develop silent ischemia without any signs or symptoms. And they would occur more in diabetic patients, in older adults, and in the women gender. So in terms of diagnosis, there are 3 items that are required to diagnose somebody with ACS: a 12-lead EKG showing ST segment elevation or depression, T-wave inversion, or a new bundle branch block with chest discomfort, as well as signs of biomarker of cell death, which is the cardiac troponin I or cardiac troponin T, as well as the patient's symptoms and their past medical history. All of these are important in diagnosing patients with ACS. The next thing we'll talk about are the goals of therapy for ACS. Definitely relief of the ischemic chest pain and controlling patient's symptoms is one of the goals, as well as restoring their blood flow to the occluded artery. We also want to prevent complete occlusion and MIs in those with unstable angina, and then we want to prevent complications of death. And in those patients who have stent or a procedure, we want to prevent reocclusion of that coronary artery. And then ultimately, we want to increase the patient's quality of life. So this slide shows some of the treatment general approaches to somebody with an ACS. Hospital admission is definitely recommended after a 911 call. If the patient's oxygen saturation is less than 90%, oxygen is given to them. But if it's not less than 90%, studies have shown that there's no benefit in giving them oxygen. Patients should also have multi-lead ST segment monitoring, as well as frequent measuring of their vital signs. They should be on bed rest for 12 hours. They should also be offered stool softeners and pain relief, as well as having the lipid panel check for their LDL cholesterol, HDL cholesterol, total cholesterol, and triglycerides. I wanted to ask the question, why do you think for these patients we would often prescribe a stool softener for them? So that is because there is this Valsalva maneuver, which when it happens, it could prevent the return of the venous blood flow to the heart. And this can occur in situations like when somebody is straining during a bowel movement, or they have a strenuous coughing episode, or when they're lifting heavy weight objects. So we want to make sure that these patients don't strain, so we give them stool softeners. And then pain relief, we'll definitely talk about the recommended pain agents that are given to these patients with ACS. So for the treatment, general approaches, we would also triage and treat the patients according to the risk categories. And I'll definitely show that slide on the next slide. We also recommend an annual influenza vaccinations for all of our cardiovascular patients. And that is because vaccinations have been shown to reduce major adverse cardiovascular events, as well as cardiovascular mortality. And then also, it has been shown that flu can trigger heart attacks and stroke. So that's why we recommend an annual influenza vaccine. And then stop smoking is our other general treatment approaches, because smoking does affect our platelets, and ACS is considered a platelet-centric disease. Okay, so this slide talks about the treatment general approaches. It's broken down into STEMIs and non-STEMIs. So in the patients who show up with an ST segment MI, they are considered at a high risk of death. So they need to have their coronary perfusion reestablished immediately, and there is an emergent revascularization. And then for non-STEMIs, it's based on whether they have low risk, intermediate risk with positive cardiac markers, or high risk or very high risk. And these risks are based on the TIMI or the GRACE risk score, and I'll show that to everyone in the next slide. But for patients who have a very low risk and they're diagnosed with a non-STEMI and their cardiac biomarkers are negative, they are generally admitted to the ward, and there is telemetry monitoring and a non-invasive stress test with either a delay or selective invasive strategy that can be done in greater than 24 hours. So it's not as emergent as a STEMI. If they have a non-STEMI and it's considered intermediate risk, and they have negative cardiac markers, and their non-invasive stress test shows that it's negative also, but if they have a positive test, then they can go to coronary angiography. But again, it doesn't have to be less than 24 hours. They can have this elective angiography in 24 hours or more. Now, if they have a non-STEMI and it's considered intermediate risk and there is a positive cardiac biomarkers, coronary angiography with revascularization is also generally recommended greater than 24 hours. Then as we progress to the higher risk non-STEMIs, for example, the high risk category, early coronary angiography with revascularization is recommended within 24 hours. And if patient is considered very high risk, and this would be in those with hemodynamic instability, they have refractory chest pain, or they have a life-threatening arrhythmia, they would need angiography in less than 2 hours. So this is more severe than the others. Okay, so as promised, here are the slides that shows what is included in the TIMI risk score for unstable angina or non-STEMIs. So 1 point is assigned for each of these criteria. So the criteria is include if the patient is greater than or equal to 65 years old, if they have greater than or 3 risk factors for coronary artery disease. So they could have a family history of coronary artery disease, they could have hypertension, hyperlipidemia, diabetes, or if they're a current smoker. And then if they also have known coronary artery disease, and this is defined as a stenosis that's greater than or equal to 50%, or if they had used aspirin in the past 7 days, or if they had severe angina, defined it as greater than or equal to 2 episodes within 24 hours, or on their EKG, there's ST changes greater than or equal to 0.5 millimeters, and there's also presence of positive cardiac biomarkers. They would get a point for each of these. These points are then added up, and the total points correlates with the percentage of risk at 14 days for all-cause mortality, new or recurrent MI, or severe recurrent ischemia that requires urgent revascularization. So as you can see, as the points move up, the percentage also increases. So at one point, they're at 5% risk, but if they have 7 points, it moves up to 41% risk. So with a high TIMI risk score, you want to go to revascularization sooner than greater than 24 hours. And then the other scoring that are used for non-STEMI is the GRACE risk score. And the GRACE score stands for Global Registry of Acute Coronary Events. And it's a risk stratification tool, just like the TIMI risk score. And the GRACE risk score estimates the risk of death following an ACS. So what are some determinants of this GRACE risk score? So age, heart rate, systolic blood pressure, serum creatinine, and then the presence of ST segment deviation, as well as cardiac arrest during admission, elevated serum cardiac biomarkers in the Killet class, all comes into play. And when these scores are added up, if your score is greater than 140, it is definitely high risk indicator for adverse clinical outcomes. So angiography is definitely recommended early on. However, if the score is between 1 and 105, it's a low predictor of clinical outcomes. So then angiography could be considered selective and be done at a later date. Okay. So now we'll go over some of the non-pharmacological therapies for ACS. So we have 4 types. We have the angioplasty percutaneous transluminal coronary, also known as PCI. So we have 2 types. We have the balloon angioplasty, and then we have the stent placement with a bare metal stent or a drug-eluting stent. So basically with these PCIs, the balloon angioplasty, we're opening up the artery by compressing the plaque against the artery wall. So I'll definitely show a picture of that. And then for the stent placements, we have several stents. We have bare metal stents and we have drug-eluting stents, and they come from different generations. So we have the first generation drug-eluting stents, and some examples are paclitaxel and sirolimus. And the idea for these drug-eluting stent is that they're eluting medication over the stent itself to prevent restenosis of that area. And then we also have second generation stents like everolimus and zoteralimus. And then we have the third generation ones like the Onyx. Then we also have arthrectomy, which is basically you're shaving off the plaque. So there's directional or rotational arthrectomy. There's also laser angioplasty, and then there's rheolytic thrombectomy. And then we have brachytherapy, which is radiation. And then we have surgery, which is coronary artery bypass graft. So I do have pictures to show what all of these non-pharmacological therapies are. The left side shows balloon angioplasty. And basically, there's a catheter that gets inserted into the radial artery, which is near the arm, and it gets threaded to the occluded artery. And then once it comes to the occluded artery site, the balloon inflates. So now it's squishing the plaque to the sides of the walls, and therefore now the passageway is open for more blood flow. So that's balloon angioplasty. And then on the right, it has the same ideology as the balloon angioplasty, but instead of the balloon being opened, there is now a stent that is open in the balloon's place. And then when the catheter is removed, the stent stays in place to keep that infarcted area open. So now the blood flow is moving through. So that's our stent placement with bare metal stents and drug-eluting stents. And then this picture shows about the atherectomy, the different atherectomies that are available. So again, it is considered shaving of the plaque. So this directional atherectomy here, it shaves the plaque on this side. And with this one, it's used more in large arteries with soft blockages. So the plaque is relatively soft, so it's easy to shave. And then on this side, we have the rotational atherectomy, which is like a rotor blader, which shaves both sides of the plaque. And these are good for plaques that are hard and or calcified. And then we have laser angioplasty on this lower left hand here. And here, the idea is that the laser vaporizes the plaque, changing it to water and gases. And this type of angioplasty are good for blockages that are too long for a regular balloon angioplasty. And they're also good for total occluded blockages. And then for the rheolytic thrombectomy, we have clot removal, and these are good for extensive clots. Sorry, I'm just getting the mouse. Thank you, Emma. And then we have brachial therapy on the left, which uses small doses of radiation that's delivered to the site, which then will slow and stop the rapid scar tissue growth. And then on the right side, we have coronary artery bypass graft. So on this side, there is an occluded coronary artery right here. I'm not sure if you can see the mouse. Oh, okay. So if you look at the internal mammary artery, there is blood flow, but in the middle, there's no blood flow. So the idea of the bypass graft is to take an internal mammary artery from either the ribs area or the legs, and then bypass it by attaching it to another artery to bypass the occluded area. So that's the coronary artery bypass graft. Okay, and coronary artery bypass grafts are usually used for when there's left main disease, meaning that there is greater than 50% stenosis in 2 or 3 of the vessels. And then it's also good for proximal stenosis of the left anterior descending artery, as well as in those who have a left ventricular ejection fraction of less than 50%. Okay, so now we'll delve into some of the drug classes for ACS. So as you see here, there are 20 agents that are being used, and we'll go over each one of them or the class itself. So we have cyclooxygenase enzyme inhibitors, we have analgesics, we have fibrinolytics, which dissolve the clots, we have nitrates, we have the thienopyridines, also known as P2Y12 agents, we have the glycoprotein 2B3A inhibitors, then we have thrombin inhibitors and indirect thrombin inhibitors. We also have the factor 10A inhibitors like rivaroxaban, and then we have beta blockers. We have angiotensin converting enzyme inhibitors, angiotensin blockers. We also have calcium channel blockers. We have HMG-CoA reductase inhibitors, and we mainly call them statins. And then we have aldosterone antagonists. We also have the cyclopentyl triazolopyrimidine class. We have the PCSK9 inhibitors, and then we have monoclonal antibodies to the PCSK9. We also have agents that can inhibit cholesterol absorption in the intestine, and then we also have anti-lipidemic agents that inhibit adenosine triphosphate citrate lysis. So the first agent we'll talk about are the fibrinolytics. So these dissolve clots, and they are only indicated in patients with a STEMI. So they are not indicated in patients who have non-STEMIs. So it's considered a class 1 recommendation in the US. And the idea is to use fibrinolytics within less than 30 minutes. It is also okay to use fibrinolytics within 3 hours of symptom onset. And there's also additional data to say that it's effective when used up to 12 hours of symptom onset. So fibrinolytics would be the drug of choice if there are delays to the PCI. So for example, if patients live in a rural area and they cannot come to a hospital institution where the PCI can be done in less than 120 minutes, fibrinolytics would be indicated for them. So for fibrinolytics, there are fibrin-specific agents and non-fibrin-specific agents, and we'll talk about those. And then there are absolute and relative contraindications. So this is important because if it's an absolute contraindication, that means fibrinolytics should not be used because the risk definitely outweighs the benefits, and that's most likely in terms of bleeding. But for relative contraindications, it depends on whether the condition is stable and if the physician feels that the benefit is greater than the risk. Okay, so here are the absolute and the relative contraindications for fibrinolytics. So in patients who have any history of intracranial brain hemorrhage bleeding, it's not indicated, so they cannot use that, as well as any known structural brain lesions, any ischemic stroke within 3 months, if they have a suspected aortic dissection, or if they have an active bleed, fibrinolytics are definitely not recommended. If there's also some closed head or facial trauma that was within 3 minutes, or if they had intracranial or intraspinal surgery within 2 months, or if they have uncontrolled hypertension that's not responding to therapy, so their blood pressure is greater than 180 for systolic and greater than 110 for diastolic, fibrinolytics are not recommended for them. Now, for the relative criteria for fibrinolytic use, if there's a history of chronic, severe, poorly controlled hypertension, or if they present and their hypertension is greater than 180 to greater than 110, or if they had a previous history of ischemic stroke greater than 3 months, or they have dementia, or they have a known intracranial pathology, these are all considered relative. Other relative criteria are traumatic or prolonged CPR, mainly greater than 10 minutes, or if they had a major surgery that was less than 3 weeks, or if there's some recent internal bleeding within 2 to 4 weeks, or if they have some non-compressible vascular puncture, or if they're pregnant, or if they have an active peptic ulcer, or if they're using concurrent oral anticoagulations with warfarin, apixaban, rivaroxaban, dabigatran, or indoxaban. All of these are relative. So if the benefits definitely outweigh the risks, then the relative criteria, you can use the fibrinolytics. So in terms of agents, we have fibrin-specific agents. So we have 3. We have tenecteplase, we have alteplase, and we have retaplase. So with the tenecteplase, it is our drug of choice at the hospital center because it's easy to use. It's an IV push item. So it's normally dosed at 0.5 milligrams per kilogram. And it also has less cerebral bleeding and less need for transfusion than the other 2 agents, which are alteplase and retaplase. So the dosing, I've left them here for you for your reference, but alteplase, unlike tenecteplase, is an infusion. So there's an IV push starting off at 15 milligram, but then there's an infusion of 0.75 milligrams per kilogram over 30 minutes, and then another 0.5 milligrams per kilogram with the max dosing listed here over 60 minutes. Retaplase, on the other hand, is similar to tenecteplase. It's an IV push item, so it does require 10 units IV push first, and then it could be repeated in another 30 minutes. And then we have the non-fibrin specific agents. So we have streptokinase in the doses listed here, but this agent is not available currently in the United States, and that's because there are some studies out there that have shown that it has inferior outcomes compared to the fibrin-specific agents discussed earlier, and then there's also a risk of allergic response with this agent, hypersensitivity. So now we'll talk about the other treatment for STEMI, which is primary PCI. So as mentioned earlier, primary coronary intervention widens the coronary arteries by greater than 90%. Fibrinolytics will widen the coronary arteries by less than 60%. Therefore, the treatment of choice is the percutaneous coronary intervention. So it has a class 1 indication, especially if it could be done in 90 minutes. And then with PCIs, the risk of intracranial hemorrhage and major bleeding is definitely lower than with fibrinolytics. And we normally would prefer it if the hospital has skilled interventional cardiologists and the necessary facilities to perform the PCI. And PCIs are recommended in those patients who present with ACS along with cardiogenic shock, or they have a high risk for developing heart failure. Okay. And then we also have something called rescue PCI. And rescue PCI is PCI that's done 12 hours after they have failed fibrinolytic therapy. So this would mainly be indicated for patients who have recurrent myocardial ischemia, they are hemodynamically unstable, or they have a large myocardium that's at risk. So they can have rescue PCI done after fibrinolytic therapy. Okay. So now we'll delve into the different medications for ACS. So initially, all of our patients are going to receive aspirin. Aspirin is an indirect thromboxane inhibitor, which inhibits platelet aggregation. It has a class 1 indications for STEMIs and non-STEMIs. Normally on the first day, they get 325 milligram or 162 milligram of the non-enteric-coated aspirin. And the reason is they want to use the aspirin that's immediate release so that it could have immediate action. If patients cannot take oral aspirin, they can also use suppositories of 300 milligram. And then on day 2, aspirin will be lowered down to 81 milligrams, but there's also situations that some patients may need to be on 325 daily indefinitely. Although aspirin is considered in the NSAID class, it's okay to use, but for other NSAIDs like ibuprofen, naproxen, we do not recommend it initially for ACS, and the reason is that in large meta-analysis, NSAID use have increased the risk of mortality, reinfarction, hypertension, heart failure, as well as myocardial rupture. So in patients that need pain medications, we would definitely recommend Tylenol or a non-selective NSAID, which is naproxen. That's the only one we would recommend if you need an NSAID class. Or we would recommend Tramadol, which is Ultram, or some of the other non-acetylated salicylates, such as choline, magnesium trilisate, or salicylate. So the bottom line here is we definitely don't recommend NSAIDs post-ACS. Okay, just finding the mouse. Okay. So the second class of drugs that's used for ACS is the nitroglycerin. They are used for patients who have ischemic discomfort, continuing discomfort. They can also control hypertension, and they can also manage pulmonary hypertension. They do have a class 1 recommendations for STEMIs or non-STEMIs. And the nitroglycerin that's initially used is the 0.4 milligrams sublingual. It's repeated every 5 minutes until a max of 3 doses. And then before EMS is called. Now, for nitroglycerin, we also have a drip that can be used if the patient continues to have refractory ischemia. So the drip starts off at 5 to 10 micrograms per minute, but it doesn't stay here. It needs to be titrated up based on the patient's symptoms and also limiting adverse effects. So we may even see nitroglycerin drips at 100 micrograms or 250 micrograms per minute. And then patches and oral nitrates can also be used after the drip is done in those with refractory ischemia. Okay, so as mentioned earlier, pain, in terms of pain for ACS, there are 2 agents, morphine and fentanyl, but pain for ACS does not have a class 1 recommendation. It has actually been downgraded to a 2B recommendation. And the reason is there's really no large randomized trials to demonstrate any improvement in the patient's clinical outcome. In fact, some possible harm can be due to the use of these narcotics, such as masking of their ischemia symptoms, as well as delaying the onset of some of the platelet inhibitors, such as clopidogrel, and we'll go over those too. So in those patients who Tylenol does not help and they absolutely need an agent, you can use this, but please keep in mind of some of these trial data. So we have morphine and we have fentanyl in the doses listed here. They are basically used if sublingual nitroglycerin is not helping the patients and the patients continue to have recurrent symptoms even after inadequate doses of nitroglycerin. Okay, so now we'll talk about the different antiplatelet agents. I know we talked about aspirin already, but we're going to be talking about clopidogrel and prasugrel, ticagrelor, and cangrelor. So out of these agents, all of them are oral except for the cangrelor, which is considered an IV form. 2 of these drugs belong to the same family. So clopidogrel and prasugrel belong to the same thienopyridine family, as well as cangrelor. Ticagrelor, on the other hand, does not belong in the same family as clopidogrel, prasugrel, or cangrelor. It belongs to that long class that was seen earlier, the cyclopentyl triazolopyrimidine, and it's quite unique. So I have a slide to show everyone on that. And then we'll definitely go over the dosing and the different clinical pearls for some of these agents. Okay, but first, I wanted to give you some update on the recent ACS guidelines that were released by American Heart Association, American Cardiology Association in 2025. And that has to do with some of the antiplatelet duration for these agents. So in the past, and even right now, our default strategy is 12 months of dual antiplatelet medications in those with low bleeding risk. But now, based on these guidelines, the duration of death is now individualized. So it's based on if a patient has a high ischemic or high or low bleeding risk. So if they have high ischemic risk and they have a low bleeding risk, their dual antiplatelet duration could be 12 months. However, if they have a low ischemic risk and a high bleeding risk, their duration could be as low as even 6 months. So we'll definitely look at those in future slides, but I just wanted to mention them here. So as mentioned, in a patient who has a high bleeding risk, there is a shorter duration for death that's recommended, and there are various strategies made by the guidelines that we'll take a look at. And then at any event, while patient is on a dual antiplatelet therapy, if they bleed, they can be switched to monotherapy earlier, meaning that they're just going to be on one antiplatelet agent. Okay. So the first drug we'll talk about is clopidogrel, and it's a thienopyridine. It's considered a second-generation thienopyridine. It's indicated for patients who are going to PCIs for STEMIs or non-STEMIs. It could also be used in patients who have an allergy to aspirin. It can also be used in patients undergoing coronary artery bypass graft. And it could also be used as medical management, meaning that there is no intervention. And it's also the agent, the antiplatelet of choice in those who are having fibrinolytics and STEMIs. Okay. So there's normally a loading dose that's involved with clopidogrel. 600 milligram or 300 milligram loading dose is recommended. So when before PCI, the 600 milligram loading is recommended, and that is because of the onset of clopidogrel. If we do not give a loading dose, the platelet inhibition onset will take about 5 days. But if we give a loading dose of 600 milligram, the platelet inhibition will be in effect in about 2 hours. And then there's also a lower loading dose of 300 milligrams in those patients who have received fibrinolytic therapy, followed by the maintenance dose of 75 milligrams daily. So as mentioned earlier, the onset of platelet aggregation for clopidogrel's pharmacokinetics, it can be detected within 2 hours. And then the 75 milligrams can also be detected by the second day of treatment. So in terms of duration and action, platelet aggregation and bleeding time can return to baseline after about 5 days of discontinuing clopidogrel. Clopidogrel is unique in that it has an active metabolite. It is a prodrug. It does require hepatic metabolism by esterase-mediated hydrolysis to a carboxylic acid derivative, and by the CYP2C19 to this active metabolite called thiol. And then clopidogrel also has some unique genotype properties on its response. So there is some variability of clopidogrel response due to the polymorphic nature of the CYP2C19 metabolism. So therefore, some guidelines have mentioned that there could be testing done for patients in selected patients because clopidogrel may not work as well. So clopidogrel has 3 types of genes, and they're known as alleles. There's type 1, and this is the normal allele. This is considered normal metabolizers. And then you have the alleles 2 and 3 that are poor metabolizers. So in these patients, the risk for major adverse cardio events is higher if they use clopidogrel. And then you also have patients who have an increased functional allele, which is 17, and they're considered rapid or ultra rapid metabolizers. So the guidelines do say that in those patients who have CYP2C19 poor metabolizing or intermediate metabolizers, they should not use clopidogrel because of the reduced effectiveness of the antiplatelet activity. They should use ticagrelor or prasugrel instead. However, if they have normal, rapid, or considered ultra-rapid metabolizers, they can safely use clopidogrel, and we will know that the antiplatelet effects will be effective here. So that's some unique properties for clopidogrel that is not seen with prasugrel or ticagrelor. Okay, so that brings us to the updated United States guidelines for clopidogrel. So right now, the guidelines recommend for initial antiplatelet therapy for ACS that ticagrelor or prasugrel be used over clopidogrel. Clopidogrel should only be used when either ticagrelor or prasugrel are not available, the patient cannot tolerate it because it's more potent, they had a bleed, or if they have a contraindication. to these agents. So we'll talk about the individual contraindications to ticagrelor or prasugrel in upcoming slides. But for now, clopidogrel, the recommendation is it could be continue for 12 months in those patients who have early invasive or even medical management. And then they could be used beyond 1 year in those patients who have a higher ischemic risk and a blow bleeding risk. Now, clopidogrel, using it shorter than a year is also reasonable, especially in those with an increased risk of bleeding. Okay. So now I want to go over some studies to show you why the guidelines suggest using ticagrelor and prasugrel over clopidogrel. Because you're probably wondering, there must be something that's beneficial in ticagrelor or prasugrel, and that's why it's in the guidelines. So that's true. In this study, the Plato study, where ticagrelor versus clopidogrel in patients with acute coronary syndromes, ticagrelor, when they compared it with clopidogrel, there was a significantly reduced rate of death from vascular causes, MI or stroke, and there was without an increased rate of overall major bleeding, but there was an increase in the rate of non-procedure related bleeding. So from this study, the rate of death from any cause reduced with ticagrelor was only 4.5%, which is statistically significant compared to clopidogrel, which was 5.9%. In terms of bleeding, there was no significant difference in rates of major bleeding between ticagrelor or clopidogrel. So the percentage is similar to 11%. And then ticagrelor was associated with a higher rate of major bleeding, but it's not related to CABG, which is statistically significant, and that includes more instances of fatal intracranial bleeding and fewer of fatal bleeding of other types. So you can probably guess that intracranial bleeding will be one of the contraindications for ticagrelor use. Okay. So the second study is the Triton-TIMI 38 study, and it talks about prasugrel versus clopidogrel in patients with acute coronary syndromes. And in this study, prasugrel therapy was associated with significant reduced rates of ischemic events, including stent thrombosis compared to clopidogrel, but there was an increased risk of major bleeding, including fatal bleeding. But the overall mortality did not differ significantly between prasugrel or clopidogrel treatment groups. And for the Triton-TIMI 38 study, prasugrel was studied in those patients who have ACS, but they have a scheduled PCI. Okay. And then there are some data that I wanted to share with everyone for the study. Some significant reductions for prasugrel in rates of MI. 9.7% for clopidogrel, but 7.4% for prasugrel. So this was statistically significant. Prasugrel was definitely superior than clopidogrel. Even in terms of urgent target vascular revascularization, clopidogrel had a 2.5% versus clopidogrel, which had 3.7%. And even in terms of stent thrombosis, prasugrel has reduced stent thrombosis at 1.1%. Compared to clopidogrel, which is 2.4%. And then in terms of major bleeding, 2.4% receiving prasugrel. However, clopidogrel had 1.8%. So prasugrel is definitely more potent clopidogrel, and that's why you may see in terms of bleeding, it has a higher percentage. Also greater in the prasugrel group was the rate of life-threatening bleeding. So 1.4% compared to clopidogrel, which is 0.9%. In terms of non-fatal bleeding, it's very similar. And then fatal bleeding, 0.4% for prasugrel versus 0.1% for clopidogrel. And this was statistically significant. Okay. So what did the guidelines do? Because of all of this data, the guidelines have made some recommendations in patients who are on prasugrel and ticagrelor, and that if at any time patient has a bleed, you can definitely de-escalate, which is lower the antiplatelet potency with using clopidogrel instead. So there's two methods. One is to change prasugrel into ticagrelor to clopidogrel, or you can use single antiplatelet therapy with just clopidogrel and an oral anticoagulant after 1 month of being on the triple therapy of dual antiplatelet therapy and oral anticoagulant therapy. So you might wonder and ask, what situations do you use dual antiplatelet therapy and oral anticoagulant therapy with either warfarin, apixaban, or rivaroxaban? So situations would be if patients have an ACS event and they also have atrial fibrillation, or they might have an LV thrombus or another VTE that requires an oral anticoagulant therapy. And then another bleeding reduction strategy post-PCI would be if patients are considered high bleeding post-PCI, they can also use single antiplatelet therapy. So they can be either on aspirin or a P2Y12 inhibitor like clopidogrel or ticagrelor after being on 1 month of dual antiplatelet therapy. So those are some of the strategies for patients who have high bleeding risk post-PCI. Okay, so now we'll talk about the agent prasugrel. So prasugrel is the 3rd generation thienopyridine. It's definitely 10 times more potent than clopidogrel with greater bioavailability, greater onset, and more consistent platelet aggregation inhibition. It doesn't have that genotype variance that clopidogrel has. Prasugrel is indicated in patients who are undergoing STEMIs in PCIs or non-STEMIs. They're only indicated in patients with known coronary artery anatomy only, so that means that it's not used for medical management. Again, just like clopidogrel, there is a loading dose followed by a maintenance dose. The loading dose for clopidogrel is 60 milligrams followed by 10 milligrams, and it depends on the patient's weight whether they get the maintenance dose of 10 milligrams or 5 milligrams. So if your patient is greater than 60 kilograms, the maintenance dose will be 10. But if their weight is less than 60 kilograms, their maintenance dose will be 5 milligrams. Prasugrel's duration is at least 12 months. And then in those patients who are undergoing CABG, it is definitely recommended to hold prasugrel for 7 days before CABG. But we do realize that there may be an emergency CABG. So when that is done, you can actually hold prasugrel for 24 hours. So one unique trait for prasugrel is that it has a contraindication for patients who have a stroke or a transient ischemic attack. In those patients, prasugrel is definitely not recommended. And then we talked about the efficacy in the Triton-TIMI 38 trial with prasugrel already. So how does prasugrel fit into our new guidelines? It's fit under the bleeding reduction strategies post-PCI, because as mentioned earlier, it's definitely more potent than clopidogrel. So if the patient has developed bleed, you can de-escalate the potency of the antiplatelet selection after 1 month of dual antiplatelet therapy. So for example, you're on aspirin plus ticagrelor or prasugrel. So now you're going to change your prasugrel to just clopidogrel for a lower potency agent and continue the ACE. Okay. So the next agent that we'll talk about is ticagrelor. So ticagrelor does not belong to the thienopyridine class. It belongs to the cyclopentyl triazolopyrimidine. And because of that, if your patient has an allergy to clopidogrel or prasugrel, you can actually use ticagrelor instead. Just like the other agents, there is a loading dose as well as a maintenance dose that's involved with ticagrelor. Ticagrelor has a loading dose of 180 milligrams with the first initial aspirin dose of 325 milligrams. And then 12 hours later, there's a maintenance dose of 90 milligrams twice a day with ticagrelor with aspirin 81 milligrams daily. So notice the aspirin dose here is 81 milligrams and not 325, and that's because higher doses used with ticagrelor can actually undermine its efficacy. So ticagrelor is recommended in those patients who are going to PCIs for non-STEMIs or STEMIs. They can also be used in patients who do not undergo a PCI, so that's considered medical management. They also can be used post-CABG, which is coronary artery bypass graft. And the Plato trial shows its efficacy compared to clopidogrel. And then I've also left you the upper note B. So if you look in the reference slides, you can also see a reference if anyone's interested in looking at the trial in detail. Ticagrelor does have an onset about 30 minutes with load. It is not a prodrug like clopidogrel or prasugrel, and it has reversible binding. So it is used for up to 12 months, but it can also be used shorter if patients have a high risk of bleed and they have a low ischemic risk. And then in those patients who have a coronary artery bypass graft surgery, it should be discontinued 5 days before the surgery. However, if there's an emergent surgery, ticagrelor can be held for 24 hours, and then they can proceed with the surgery. So ticagrelor fits into our guidelines in those patients who have an increased risk of bleeding, and they can also use a shorter duration. So, for example, after 1 to 3 months with dual antiplatelet therapy, then ticagrelor used by itself for a total of 12 months is also okay. And this is highlighted in the Twilight trial. And in the Twilight trial, after 3 months of dual antiplatelet therapy with ticagrelor and aspirin, patients were randomized in this trial to use either ticagrelor by itself or to continue the DAP for 12 months. And then after about 1 year of monotherapy, the trial authors found that there was less major bleeding. There were less major bleeding, as well as the secondary endpoints of death from any cause, like non-fatal MIs or stroke. Those were similar between the two groups. So again, monotherapy can be used for ticagrelor. It does not have to be used with aspirin. And this is highlighted in the Twilight trial. And then the other recommendations for the guidelines for ticagrelor is that in those with high bleeding risk, post-PCIs, they can use single antiplatelet therapy. And again, using aspirin or a P2Y12 inhibitor like ticagrelor or clopidogrel after 1 month of DAP is also okay. So if you remember earlier, we looked at the trials and we had said that there was a higher incidence of intracranial hemorrhage compared to clopidogrel. So therefore, the contraindications are if patient has a history of intracranial hemorrhage, ticagrelor would not be recommended, as well as any pathological bleeding, such as a peptic ulcer, ticagrelor will not be indicated. So ticagrelor is currently our workhorse agent here at the hospital center. So I also included some information on the slides for side effects, as well as the percentage of these side effects. So there's a high percentage of dyspnea, about 14 to 21%, and they think that this is related to the off-target effect of some adenosine reuptake. However, this dyspnea is mild and moderate in intensity, and normally is transient. It will go away. It will resolve without discontinuing therapy, and you could continue therapy, and there's no adverse changes in cardiac or pulmonary function. So dyspnea, we have seen can affect patients within like a month, but then it does go away and patients do not need to stop therapy. Some other side effects of ticagrelor would be hemorrhage, ventricular pauses, dizziness, nausea, as well as some transient increase in serum creatinine, and then it can also cause gout too. So here I have a summary slide on the guidelines, and it talks about initial selection of oral P2Y12 in a patient who is initially admitted for ACS. So we'll go over these so that way it kind of summarizes everything that we have talked about so far. So in a patient who presents with ACS and PCI is selected, they have a non-STEMI or a STEMI, aspirin plus ticagrelor or prasugrel are our first choice recommendations. Clopidogrel can be used when ticagrelor or prasugrel are not available, or a patient has a contraindication such as a stroke with TIA or an intracranial hemorrhage, or they cannot tolerate it because they have a GI bleed due to these agents, then you can use clopidogrel. In those patients who are undergoing coronary artery bypass graft, the initial antiplatelet agents are aspirin plus ticagrelor or clopidogrel. So prasugrel here is not recommended. So we would continue the aspirin during the CABG and then start the P2Y12 like ticagrelor or clopidogrel when it's safe post-operatively. And then in those patients who are being medically managed, meaning there's no planned invasive evaluation, the antiplatelets of choice are aspirin and ticagrelor. Clopidogrel can also be used if ticagrelor is not available or if there's a contraindication. So notice here, prasugrel is not recommended in those who have no planned invasive evaluation or for medical management. And then in patients who select fibrinolytics and STEMIs, the antiplatelets of choice are aspirin and clopidogrel. So here, ticagrelor and prasugrel are not recommended. It is just aspirin and clopidogrel. Okay. And then this slide shows the duration of antiplatelet agents. So we have the default strategy of 12 months for most of the dual antiplatelet agents. And then we have bleeding reduction strategies post-PCI, and also high bleeding risks post-PCI strategies. So there are 3 strategies under the bleeding reduction strategies post-CI. So the first strategy is we use dual antiplatelet therapy with aspirin and ticagrelor for the first month. And then we discontinue the aspirin 1 to 3 months post the PCI, and then we just use single ticagrelor monotherapy. So that would also be considered class 1 and okay to use. Then in those patients who have an indication for triple therapy, so now they're on dual antiplatelet therapy and oral anticoagulant therapy, such as they have an ACS, along with an AFib indication or a VTE indication, the recommendation here would be to discontinue the aspirin 1 to 4 weeks post the PCI, and then the patient will be on a single antiplatelet therapy plus the oral anticoagulant therapy for 12 months. So they can be on clopidogrel monotherapy, and then they can be on warfarin, apixaban, or rivaroxaban. And then in those patients who are on DAP, the third bleeding reduction strategy is to de-escalate the potency of ticagrelor and prasugrel after 1 month of post-CI. You can change it to clopidogrel use instead. And then you'll be on aspirin and clopidogrel up to 12 months. And then the last strategy for the high bleeding risk post-PCI group patients, the patient is on DAP with aspirin and a P2Y12 inhibitor for 1 month. Then after that 1 month, the aspirin stops, or the P2Y12 inhibitor is used greater than 1 month. So you can use aspirin or P2Y12 after 1 month by itself. And that's considered single antiplatelet therapy. Okay. Okay. So as mentioned earlier, we do have an IV form of the P2Y12 inhibitor, and that is our cangrelor drug. So cangrelor is very unique. It inhibits platelet in just 2 minutes versus the other oral agents, which is 2 hours. So it's considered a direct and reversible inhibitor of the platelet 2 white P2Y12 inhibitors. Because it's quite expensive in our hospital, we are reserving it for patients that are undergoing PCI. They haven't been pre-treated with an oral P2Y12 inhibitor, and they weren't given a glyco-2B3A inhibitor. So the dosing for cangrelor is 30 micrograms per kilogram IV bolus followed by an infusion. An infusion usually lasts about 2 hours, or the duration of the procedure, whichever is longer. So once we're on cangrelor, we also have to keep in mind that we now have to consider using oral agents to transition. So there are two methods for transitioning cangrelor based on which antiplatelets we choose. If we choose to use the cangrelor, we can administer it any time during the cangrelor infusion or immediately after the cangrelor is discontinued. However, if our plan was to choose the agents prasugrel or clopidogrel, we have to give it only after cangrelor is DC, and that is because prasugrel, clopidogrel, and cangrelor belong to the very same thienopyridine class. So if we give it while it's infusing together, then we're going to be competing for the receptor sites. So we have to give it only after the cangrelor is DC'd. Okay. Now we'll talk about the different medications that are used adjunctively for ACS. We have the direct thrombin inhibitor known as bivalirudin, and it's used for PCI support, where the dose was here for you, as well as post-PCI infusion for primary percutaneous coronary prevention. I also wanted to mention some clinical pearls for bivalirudin is that it is renally metabolized. So in those patients with poor kidney function, the dose is reduced, as well as those who are on hemodialysis. And bivalirudin is normally discontinued at the end of the PCI procedure. The efficacy of bivalirudin was shown in the Horizons AMA trial. And in this trial, it did show a significant reduction in net at-risk clinical events. So the composite of death, stroke, reinfarction, or unplanned revascularization or major bleeding at 30 days, all of these were decreased with bivalirudin. So another adjunctive therapy for ACS is the unfractionated heparin. So unfractionated heparin is dosed at 60 units per kilogram IV bolus, followed by 12 units per kilogram per hour. It's used for medical management or with fibrinolytic therapy, or in those going to PCIs. So normally the heparin drip is only continued for 48 hours unless there is a reason to continue the heparin drip, like an LV thrombus. And the dosing here is lower than in a standard dosing for patients who have, for example, atrial fibrillation or PE. And then I've also listed the doses during support PCI for you here. Now, enoxaparin, the low molecular weight heparin, is also used as an adjunctive therapy for ACS. And with this, the initial therapy is 1 milligram per kilogram subcutaneous every 12 hours. It does need renal adjustments, unlike heparin. In those patients who have creatinine clearance of less than 30, the frequency goes down from Q12 to daily dosing, but still at 1 milligram per kilogram. So what's unique about Lovenox is that there are dosing for support PCI, and then there's also an IV dose of Lovenox that is just used ×1 before maintenance dose of sub-Q. So for example, in support PCI, if patients had previous treatment with Lovenox, if their last sub-Q dose was administered 8 to 12 hours earlier, or they only got one sub-Q dose of Lovenox, when they go to PCI, they will get a 30 milligrams IV dose of Lovenox. So this is the only time we will see the IV dose. And then afterwards, they will get the sub-Q dose. And the durations for this Lovenox is for about up to 8 days or throughout their hospitalization. Another area that we will see the 30 milligrams IV dose of Lovenox is when Lovenox is used adjunctively with fibrinolytic therapy. So in patients who are less than 75 years old, a 30 milligrams IV bolus of Lovenox or enoxaparin use is followed in 15 minutes by the 1 milligram per kilogram sub-Q every 12-hour dosing. So the max dosing is listed here for you. We also have to keep in mind that when we use fibrinolytic therapy with Lovenox, if our patients are greater than 75 years old, there's no bolus dose of IV Lovenox. There's just a sub-Q dose that at a reduced dose of 0.75 milligrams per kilogram every 12 hours, and we're not going to exceed a 75 milligram dose for the second dose. And then if the patient's renal function is considered less than 30 mils per minute for creatinine clearance, the frequency also gets reduced down to Q24 hours. And again, Lovenox is used for about up to 8 days or until the patient gets revascularized. So that is Lovenox, enoxaparin. Fondaparinux is also used. It's a factor 10A agent. The first initial dose is 2.5 sub-Q daily, but just like Lovenox, when it's used for fibrinolytic therapy, there is an IV bolus that can be used at 2.5, and then that is followed by 2.5 sub-Q daily on day 2 for the hospital stay, and this can be used up to 8 days or until the patient gets PCA. Another anticoagulant class is the glycoprotein 2B3A receptor inhibitor. So the agents here are eptifibatide or tirofiban. For patients who need a glycoprotein 2B3A inhibitor, they are normally patients who are experiencing continuous ischemia, they have elevated troponins, or they have other high-risk features. And then we have the oral factor 10A inhibitors. So we have rivaroxaban at a dose of 2.5 milligrams twice a day, plus aspirin plus clopidogrel. Now the use for rivaroxaban is off-label. It's normally used after the patients have been stabilized with initial other ACS management. So for rivaroxaban, it does reduce the risk of death from cardiovascular causes, MI or stroke in patients with chronic coronary artery disease or peripheral arterial disease. And in the COMPASS trial, rivaroxaban did show superiority plus aspirin in reducing cardiovascular death, stroke, or MI. So rivaroxaban reduced all of those composite endpoints by 5.4% compared to placebo, which is 4.1, and that was statistically significant. So when would rivaroxaban be used? So it may be indicated in high-risk patients with stable atherosclerotic vascular disease and in those who are not high risk for bleeding, because again, you're using 3 agents. And then caution should be used for this patient if we choose to use this, because there has been some significant major bleeding that was observed in the trial. Okay. So our next class of therapy that's used for ACS is our beta blockers. So our beta blockers reduce contractility, they reduce the heart rate, they reduce myocardial oxygen demand, as well as decrease remodeling of the heart. And then they also increase diastole. So they are recommended for STEMIs or non-STEMIs, and this would be the oral beta blockers. The oral beta blockers now have been recommended for at least 1 year. They are continued indefinitely if patients have another diagnosis, for example, heart failure with an ejection fraction of less than 40%. So some of the beta blockers that are used are listed here for you, as well as doses. So we have metoprolol tartrate, we have metoprolol succinate, we have carvedilol, atenolol, and bisoprolol. So We also have IV beta blockers, but they don't have a high recommendation. They fell from class 1 to class 2A, and they are only indicated in patients who have concomitant hypertension and ACS. So that is because there really has been no evidence to support their routine use. Their recommendation is only for those who are hypertensive at the time of the ACS presentation, and this is because the COMET trial where beta blocker use was shown to increase the risk of cardiogenic shock, especially in those who are greater than 70 years old, and in those who have a heart rate of less than 60 and their systolic blood pressure was less than 120, they have an increased risk of shock if they use IV beta blockers. So we try to not use them unless there is a true indication for it. The other class that we'll talk about is the calcium channel blockers. So they have a class 2A recommendations for STEMIs and a class 1 for non-STEMIs. They are more like for second line. They are for patients who are still experiencing continuing ischemia, chest pain, even after appropriate doses of nitrates or beta blockers, or they can be used in those patients who have an intolerance to beta blockers or a contraindication. So we have diltiazem, verapamil, nifedipine, and amlodipine, and the doses listed here for you. And then another class of agents that we have are the angiotensin converting enzyme inhibitors. They have an indication for non-STEMIs or STEMIs in patients with heart failures. So their EF is less than or equal to 40%, or they have type 2 diabetes, or their chronic kidney disease. They are indefinitely used for those with an EF of less than 40%. And I've included the agent for you as well as the targeted doses that were used in the clinical trials. So obviously we're going to start low, and as the patient's blood pressure, hemodynamics, and kidney functions are all good, we can move up to the target doses as the patient also tolerates too. So the doses we have are captopril, enalapril, lisinopril, ramipril, and trandolapril. We also have the angiotensin receptor blockers. So they are indicated for non-STEMIs or STEMIs. They are more used in those who have an intolerance to an ACE inhibitors, but they can also be used in those patients who have heart failures or with an EF of less than 40%. They would be used indefinitely as blood pressure and kidney function allows. And we have canastatin and valsartan that was studied in the trials with the target doses. So again, use the initial dose and then titrate up to the target dose as patient's blood pressure, hemodynamics, and kidney function levels. So the next group of drugs we'll talk about are the aldosterone antagonists. They are indicated for MIs and patients with an EF of less than 40%, and patients may either have diabetes or heart failure symptoms who are already receiving an angiotensin converting enzyme inhibitor. They have a class 1 indication. They are used indefinitely, and the drugs that are listed here with their target doses are eplerenone and spironolactone. And the efficacy of the aldosterone antagonist was seen in the EPHESUS study, which demonstrated significant survival benefits in post-MI, especially in patients with evidence of heart failure. Even though it was studied in eplerenone, you can still use spironolactone too because they're in the same family. And with these two agents, we have to keep in mind that there are some contraindications, meaning that there are situations they are not recommended for. So if a patient has a potassium that's greater than 5.5, or if they have poor kidney function, defined as a creatinine clearance of less than or equal to 30 mils per minute, or to break that down, if they have a serum creatinine in a male patient that's greater than 2 milligrams per deciliter, or a serum creatinine of 1.8 or greater in a female patient, these aldosterone antagonists would not be recommended. finally, we'll talk about the lipid-lowering agents that are used for ACS. We have several agents, 5 classes to be exact. We have the statins, the HMG-CoA reductase inhibitors. They are considered class 1. There are 2 agents here that are recommended for ACS, and both of the doses here that we see, atorvastatin 80 and rosuvastatin 40, are considered high-intensity statins. So for ACS patients, we tend to jump to the higher end of the high-intensity statin rather than use the lower end. I'll give you an example. Atorvastatin 40 and 80 milligrams are still considered high intensity, but in those patients who present with ACS, we normally will opt to go with a higher dose, which is 80 milligrams of atorvastatin. And that is also similar to rosuvastatin. So 20 to 40 milligrams is considered high intensity. Then a patient who presents with a heart attack, we will go directly to 40 milligrams. Keep in mind that Crestor is renally metabolized as well. So in patients with poor kidney function, Lipitor would be the preferred agent. And then we have the PCSK9 inhibitors. We have evolocumab and alirocumab. And then the next slide, I will definitely show you the percentage of LDL reduction that is for each of these agents. We also have bempedoic acid at 180 milligrams daily. We have esizimbi, 10 milligrams orally daily. And then we have inclisiran, which is a sub-Q agent that's used once and then repeated 3 months. And then there's a maintenance dose. So in 2025, the ACS guidelines also updated some goals for lipid lowering for these agents. In the past, the LDL goal was less than 70 for most of these patients. Now the LDL goal has been stricter, and now it is less than 55 milligrams per deciliter for these ACS patients. So this slide shows you the percentage of LDL reduction with some of the anti-lipidemic agents. As you can see, PCSK9 monoclonal antibodies reduce the LDL the most by 60%, followed by high-intensity statins and inclisiran, which reduce LDL by 50%, then bempedoic acid by 20%, and then finally esizimbi 15 to 25%. Okay, so this flow chart is a summary of all of the stuff that we talked about for lipid management that I would like to go over it with everyone so then everyone can see what the new guidelines recommend. So in patients who are being hospitalized with a heart attack, their baseline lipid profile should be done to assess their LDLs, HDLs, total cholesterol, and triglycerides. So on the far left, if patient is not on a statin therapy, or if their statin therapy is considered low and moderate intensity, they need to start on a high intensity statin, and then they may consider the addition of esizimbi. And after starting the high intensity statin, about 4 to 8 weeks later, therapy can be adjusted based on their next lipid target levels. So they'll get some blood work, and then whatever their lipid levels say, we might need to either add another esizimbi or move to a more potent agent. Now, if patient is already on a maximally tolerated statin therapy and their LDL is less than 55, they can still continue their high-intensity statin and then have their lipid profile reassessed in 4 to 8 weeks. But if they come in and the LDL is between 55 and 69, there could be some addition of non-statin LDL therapy. It could be reasonable to add another agent to further lower it down to 55. And then if patient comes in with an ACS and their LDL is greater than 70, we definitely need to add a non-statin LDL lowering therapy. Perhaps we need to add PCSK9 or esizimbi or bempedoic acid or inclisiran. And then with all of these agents, it does take about 4 to 8 weeks for efficacy for a change in dose to see what the new dose should be afterwards. Then in patients who refuse a statin therapy or they become intolerant because they have severe muscle aches and pains, you can add a non-statin LDL lowering therapy here and then reassess their lipid profiles in about 4 to 8 weeks as well. Okay, so finally, in summary, ACS or acute MI is a condition of signs and symptoms of myocardial ischemia. It does include unstable angina, non-ST segment MI, as well as STEMIs. The pathogenesis of ACS involves the atherosclerotic plaque, rupture and erosion, and ultimately a thrombus formation. There's risk stratification with TIMI and GRACE scores, as well as optimizing guideline-directed medical therapy that we talked about, supplemented by coronary angiography, such as PCIs, or coronary artery bypass surgeries in selected patients that are keys to appropriate therapy for these patients. I do have some knowledge check questions for everyone. I'm not sure if I can see your response, so I'll leave it to Lemo.
So we're going to ask the questions, and then we will give you the answer because we cannot see the chat of this.
Okay. So for question number 1, myocardial infarctions includes STEMI, aortic dissection, non-STEMI, or D, which is A and C. So the answer here would be A and C. So aortic dissection is not a heart attack. So question number 2, the non-ST segment MIs cause total occlusion of the coronary arteries. Is this true or false? So this would be false because it could cause partial or intermittent occlusion of the coronary artery. And then number 3, all of the following are some signs and symptoms of ACS except the diaphoresis is sweating, and then crushing pain, C is nausea, D is diarrhea, and E is indigestion. But all of them are signs and symptoms except diarrhea. So D would be the answer. Question 4, which fibrinolytic agents are indicated for non-ST segment ACS? Is it alteplase, A? Is it B, tenecteplase? Is it C, all the above? Or is it E, none of the above? So the key here is fibrinolytics and non-STEMIs. The answer would be none of the above, because we have said that fibrinolytics are only for STEMI patients where there's a full occlusion. So question number 5, percutaneous coronary intervention are preferred over fibrinolytics in STEMI patients because they widen or open the coronary arteries by A, greater than 50%, B, greater than 60%, or C, greater than 90%. So the answer would be C, PCIs open the coronary arteries by 90%, fibrinolytics open the coronary arteries by 60%. Question number 6. The loading dose of prasugrel is 60 milligrams, followed by blank in a patient that weighs less than 60 kilograms. So prasugrel is one of those unique agents for maintenance dose. It's weight-based. So the answer here would be 5 milligrams, since the patient weighs less than 60 kilograms. So C is the answer. Number 7, patient is allergic to clopidogrel. It is being medically managed for non-STEMIs. Which antiplatelet should be recommended besides aspirin? Is it A, taclopidine, B, prasugrel, T, ticagrelor, or D, cilostazol? So remember we had said that clopidogrel falls into the same family as prasugrel and cangrelor. So we definitely can say prasugrel is out. So the answer would be ticagrelor because it's in a different class. And ticlopidine is no longer available. And cilostazol is an antiplatelet agent, but it's used for peripheral arterial disease. Question number 8. So the bolus dose of enoxaparin 40 milligram IV is initially used in patients with STEMIs who are less than 75 years of age, followed by 1 milligram per kilogram sub-Q Q12. Is this true or false? So the answer is false. So the dose for Lovenox should have been 30 milligram, but in this patient who is less than 75 years of age, you can still use it, but if they're greater than 75 years of age, then the bolus dose is omitted. The answer is still false. Question number 9. Eplerenone therapy is indicated in post-MI patients with either heart failure or diabetes comorbidities. Patients should not be on eplerenone if they have the following. Is it A, an EF of less than or equal to 40%, potassium less than 5, serum creatinine in females less than 1.5, or serum creatinine in males greater than 2? The answer would be D. For serum creatinine in males greater than 2, it would be contraindicated. And then the last question, which statin regimen is appropriate for ACS therapy? Is it A, pravastatin 20 milligrams daily? Is it B, simvastatin 40? Is it C, atorvastatin 20? Or is it D, rosuvastatin 40 milligrams daily? So the answer is D, rosuvastatin 40 milligrams PO daily. It is more high intensity than the atorvastatin 20, which is not considered a high intensity statin. And the other two agents, pravastatin and simvastatin, are definitely not high intensity statins. Okay. And these are my references. Thank you so much, everyone, for listening. Thank you, Loma, for inviting me. And I hope everyone have a great evening. And I can answer any questions if anyone has. Thank you again.
Thank you so much, Dr. Lee. Thank you for this thorough review of ACS guidelines here. And thank you, Dr. Lama, for arranging this. We do actually have one question in the chat regarding cardiorenal patients in setting of ACS. Can you elaborate more on the role of guideline-directed medical therapy regarding cardiorenal patients in the setting of ACS, risks versus benefits?
Contraindications? Like
the guideline-directed medical therapy in cardiorenal patients in the settings of ACS, risk versus benefits.
Okay, so for ACS patients for cardiorenal, if they have an ACS event, they are still recommended to use PCIs, mainly more than medical management. However, if they need medical management, we're going to have to select agents that do not affect the renal failure or renal insufficiency. So luckily, most of the antiplatelets are hepatically metabolized, so you're okay with those agents. I can see the statin therapy. You might have to choose Lipitor over atorvastatin in those with poor renal function. And then for the other adjunctive therapy, you might have to use heparin instead of Lovenox. That might be one, enoxaparin. And then beta blockers, you can still use ACE, angiotensin receptor inhibitors, and ARBs, as well as spironolactones. I may see that once your renal function improves, you can be on those agents. So again, it is tailored toward the medications that are metabolized renally for those patients, but most of these patients should still be okay with antiplatelets, statin therapies, beta blockers, ACE or ARBs, calcium channel blockers if they don't respond well to beta blockers, and statin therapies.
Would this change in the event of dialysis?
So with dialysis, again, PCIs would be recommended, but if you need medical management, the only medication group that I see that might require you to choose another agent would be the statins, specifically rosuvastatin, your ACE, inhibitors, your ARB inhibitors, and your aldosterone antagonists.
And that's mainly because those agents can increase the potassium level, and we want to avoid agents that increase the potassium in patients with dialysis.
Yeah, but they still would get their antiplatelet agents. Yes.
All right, thank you so much. Any other questions, guys? Oh, here's the follow-up questions. What about Entresto in heart failure, ejection fraction less than 20? Heart versus kidney. I'm not sure what did you mean, Maher. If you want, you can unmute yourself and ask directly.
So
Hi. Okay. Thank you first for this lecture. I really like when I see heart failure patient who is like kidney function is worsening. You know, like when a heart failure patient like with STEMI or non-STEMI or severe STEMI who end up like bradycardic or like they see low cardiac output. Uh, what is the rule of like guideline directed medical therapy like Entresto? So now we are trying to like relieve the afterload on the heart, and on the same like manner, it will affect the kidney negatively. So here, what to prioritize? Like we know, to treat the cardiorenal, you should treat the heart or like relieve the volume overload. And versus like the interest to should contain the AS or ARBs like can affect the renal artery or the effort arterial dilation. So it's like confusing and controversial to use. So that's why like what was my question. So thank you, Maher. Thank you, Dr. Leah. Yeah.
So right now, Entresto isn't one of the agents that are recommended in ACS by itself. But if the patient has a concomitant comorbidity like heart failure that's involved, then Entresto would be an agent, and you wouldn't be using the ACE or the ARBs for that. I'm not sure about the 20% thing.
So basically, what Dr. Lee is saying that you would recommend to use Entresto in patients with heart failure and acute coronary syndrome, or in patients with heart failure with reduced ejection fraction.
Right. But not by ACS itself, because it hasn't, I don't think I found much studies that support the use of Entresto in ACS. So it's still ACE or ARBs for ACS, but if you have concomitant heart failure, then you can use Entresto in place of ACE or ARBs and aldosterone antagonists.
So do you think, Dr. Lee, do you think that's because Entresto is more of a newer agent and maybe studies have not been done in using Entresto in acute coronary syndromes?
Yes, Mama, yes, because it's relatively new. It's just been out for a couple of years for heart failure, so it hasn't been included in the guidelines, and they haven't been looking at it much.
So maybe in the future studies will show us that you can also use Entresto in acute coronary syndromes, along with the ejection fraction less than 40% for heart failure patients.
Yeah. Okay, thank you.
Yeah, those are really good questions, and we're really happy to hear the questions. And we talked about a lot of different medications, and these are the latest guidelines according to the United States standards. And we know that some of these medications, some of them may not be available overseas. But we will be happy to answer any more questions if there are any.
There's another question, Dr. Lee. There's I believe a group working on a literature review regarding guideline-directed medical therapy after MI and real-world practice, and they would like to contact you by email if you're available. Are you okay sharing your email with the audience?
Yes, I'll be happy to. I don't know how to type it in the chat.
Yeah, you can.
I'll type it on your behalf. I do have your email.
Oh, okay.
Yeah, so her email is victoria.lee@medstar.net. So Victoria dot Lee L-I-L-Y. I'm sorry, L-Y at netstar dot net N-E-T.
Any other questions, guys? This is the first time actually we're trying to have fully English webinars here. We do really appreciate Dr. Lee. We usually try to kind of mix between English and Arabic. If you guys have any questions, comments, if you would like to ask in Arabic, we will be happy to translate for you. إذا حدا عنده سؤال يا جماعة شكرا على حضوركم معنا. هي أول مرة بنعمل محاضرة بالإنجليزي بشكل كامل. إذا حدا عنده سؤال وحابب يسأله بالعربي نحن ممكن نساعد بالترجمة، أو إذا حابين تكتبوه بالشات كمان ما في مشكلة. شكرا كثير لحضوركم. I guess if there's no further questions, we'll go ahead and end this meeting. Thank you again, Dr. Lee, for having us here and reviewing ACS guidelines with us. We appreciate your time and effort here and putting the slides. Thank you, everyone, for attending, and hope you have a great day.
Thank you again. Bye-bye.